Okay, well, I will introduce her. We have Dr. Hedva Levy. She's a board certified in both sorry, I'm gonna mess this up, pharmacotherapy and geriatrics. Her book, Maybe It's Your Medications, was published in 2023. Dr. Levy focuses on promoting the safe and effective use of medications in older adults. She obtained her Doctor of Pharmacy degree from the University of Michigan and completed a pharmacy residency at Shands Hospital in Gainesville, Florida. And let me just, sorry, see this slide? Oh,
I'm here and good morning.
good morning.
And I wanted to ask, is it okay if I share the slides I have? Because I added one extra for clarity for perfect.
Absolutely.
All right. Hey, Dara, it's good to see you
Good
again.
to see you
It's
too.
been a minute.
Thank you for being here.
Thank you so much. I appreciate it. Shall I go ahead and jump in? I didn't want to cut Lake off. And Lake, it's good to see you in person, put a face with the name. So thank you so much for the introduction. Um, okay. So I'll jump in. Am I good with the screen share?
Yes, you're
Okay.
I'm
good.
just going to get to my
Mhm.
slide version here, right? Okay, perfect. All right. So thank you so much for inviting me. And like I said, I met Dara over a year ago at the CSA Certified Senior Advisor Conference. And it's been a long time coming, so it's great to be here. And you guys have such a phenomenal network. I was listening in a little bit and all the education and resources you have. So today I have till the top of the hour. I want to leave time for question and answer. So please get your thoughts together and as I go through my prepared material. But I am, as Lake mentioned, I'm a clinical pharmacist. I'll talk a second about my work in the homes and what I do with older adults, but today is about polypharmacy. So my objectives are listed out here, and basically on the next slide, what I'll walk through, what is polypharmacy, differentiating appropriate from inappropriate polypharmacy. I'm going to talk about the consequences of too many medications and highlight a couple of the drug classes that we are more concerned about in older adults, just to give you a sense of what some of those medications are. And then finally, I want to leave you with strategies for how we can be safer about medication use. You can advocate for your clients if you're caring for a loved one yourself, or as we all get older, and we have medication issues to deal with. So hopefully you'll get some good tips is what I want you to leave with for sure. So about me. So I'm here in St. Louis, Missouri. I have a very unique business where I go into people's homes to do very thorough medication reviews. I look for a range of medication related problems and provide a report to the patient to help them be more to take their medications more safely when there are things that we can address, be it over the counter or supplement use, and then bring any prescription medication concerns to the physicians where there can be resolution in addressing potential problems that way. Um, in working with the people in their homes for over 2 decades, I saw time and again where problems were preventable if patients knew what to ask or how to be more involved in their medications, just to be aware of their drug therapy and why maybe they should stop and ask questions of their pharmacist or physician. And from that is where the passion for my book came in. So I'm going to mention it, just it's a resource out there, because we don't really talk about our medications. So all of this kind of goes together. And now when I am able to talk about this message of we need to talk about our medications and think about this overprescribing possibility, which I think goes on an awful lot, there's other resources out there. So just to pause and ask, are you aware that there is a geriatric specialty in pharmacy? A lot of people, as I'm talking, they are aware of that, which is great. But I am a senior care pharmacist, and geriatrics is a specialty within pharmacy. Just like you can't give a child rather, adult medications, we have to be more careful with the medicines that we give to our older adults. It might be drug selection, it might be lower doses. And then, as I mentioned, I look for a range of medication-related problems. Well, what am I referring to? There's 8 categories that have been defined, and I kind of work when I do my medication reviews off of those 8 categories. And it includes things you might imagine like drug interactions and adverse reactions or side effects, but it also includes unnecessary medication use, and under treatment or patients not receiving proper drug therapy, as well as improper drug selection based on one's age or kidney function or things like that. So we know that older adults are at greater risk of having medication-related problems, which is why I love my profession. I've created this career of working with older adults specifically. How can we prevent those problems? And hopefully you'll get a sense of how you guys can help prevent those problems in your work as I go through my talk today. So there's 5 reasons I identify why older adults are at risk. We'll be talking about the multiple medication concern, but you can imagine multiple prescribers increases that risk. Are the doctors talking to each other? And we have so many specialties in pharmacy, in medicine, you can imagine. The next 2 boxes are big words, the pharmacokinetics and pharmacodynamic changes that come with aging, but that's just to, that basically refers to how our bodies handle medicines. As we get older, we don't handle them as efficiently. We may not be able to transform and clear them from our body as easily, so they might accumulate in our body and stick around a little longer. And the other piece is the pharmacodynamics. We are more sensitive to the effects of medicines as we get older. So these 2 pieces come into play when I talk about those certain drug classes that are higher risk, and you'll have a better understanding. And then the last piece I won't have time to go into, but think about new drugs that come on the market. Are they really studied in older adults? And the answer often is not so much. So we have increased risk in older adults because of that. And sometimes doctors are pulling in a brand new medication when maybe we don't have the safety information about that drug in older adults. So just something to think about. So getting into this concept of the polypharmacy and medication use, just recognize that older adults significantly take more medications than younger populations. It's the unusual older adult who does not take a medication. And you just comparing the far right column of 41% of older adults take 5 or more medications. That's more than twice as much as middle-aged adults and 4 times as much as that general population. So just know it is a much greater issue in older adults. And remember, they're using over-the-counter products and dietary supplements along with those medications. The trend is really striking. So I graduated pharmacy school in 1990. So when I was a student, 13% of older adults took 5 or more medications. That has consistently been increasing over time. Most recently, the number is 44%. I had 41% on the earlier slide. That was just from earlier data. So this trend is increasing. And is this our new normal, that we just take this many medications? But is it okay? So what is polypharmacy?
Oh.
I hope you guys are familiar with that term already, but by simple definition, it refers to multiple medications, poly being many or multiple, pharmacy referring to drugs. And there is no distinct number that we all go by, but a commonly accepted number is 5 or more. And that's why I was highlighting that percentage, that 44% of older adults in the US today take 5 or more medicines. It can be perfectly appropriate, right? Medications that all have a valid reason for use, where the side effects are very minimal or non-existent, the benefits are great, and that's important. Certain health conditions require more medication. So when we look at patients specifically with diabetes or heart disease, heart failure, for example, patients much more commonly will be taking polypharmacy, right? 5 or more medicines. But as long as, like I mentioned, no side effects, benefits outweigh the harms, all is good. What we're concerned of with polypharmacy is when we have the inappropriate use, or medication overload is another way to refer to inappropriate polypharmacy. And there's a few definitions here, but we'll dig into that as we go through this talk. So one definition of inappropriate polypharmacy is the use of more medications than are clinically warranted, more than's needed, or using unnecessary, ineffective medicines or harmful drugs. So in essence, inappropriate polypharmacy or medication overload simply means we have more harms compared to the benefits of those medications. And it's not, you may be surprised, but I see it often where patients will continue medications despite a side effect, but often we don't recognize that the side effect is from a drug. So a patient is continuing it, maybe another medicine is added, and that's what this inappropriate polypharmacy is all about. And that's why I do what I do. And I'm so glad you guys are sharing this, talking with me about this information. This is a typical medication list, right? So this person here is on 15 medications. But what I want to highlight when we get into polypharmacy, and you guys probably have seen this in your clients, we've got 2 injectables highlighted in magenta for you. There's some over-the-counters in yellow for you. There's a topical cream that the patient is taking, and then 2 different inhalers. And from a pharmacist, I can tell you that each of those inhalers has a different mechanism for how the patient has to use it, right? So the instructions of taking these medicines and taking them properly and managing these drugs can be complicated. And that's what part of the problem that older adults are dealing with, and you guys see that all the time. And also clearly 5 or more medications here. This is a drug list where the person has less than 5 medications, right? But if I would tell you that this esomeprazole Nexium was added when the patient was in the hospital and it came home with the patient when they were discharged from the hospital, but there was no need for it at home. There was a precautionary use in the hospital. This is another example of inappropriate polypharmacy, right? An unnecessary medicine once this patient comes home. So it's not just that number we have to look at. We have to look at the quality of prescribing. How can you help patients identify, are they having inappropriate polypharmacy? I definitely would say number alone, it's reason to kind of hone in, is everything still needed? But we can dig a little deeper. I call these my pharmacy 101 questions. So we can think about why a person is prescribed each medication. Is any drug that is prescribed without a valid clinical reason for use or an indication, that is a red flag, or certainly a cautionary flag. Why is it prescribed? So that's always a start. I always tell people, if you don't know why you're taking a medicine, that's a conversation you need to begin with your doctor. Any drug that's prescribed beyond the recommended duration. So, and there are certain drugs where we do have a defined duration of treatment, and I'll highlight one class of drugs for sure with that. But so certainly a course of steroids. I've seen a patient who taking an antibiotic for, I think it was at least 2 months when I met with her, and there was no reason for that antibiotic to be continued. So are we taking things beyond, and how it got continued is a whole other story. A little bit of mystery, but it was something you never know what I never know what I find when I meet with my clients. But the drugs for heartburn or reflux, we'll talk about those, are another one where they should be used for a short period and then stopped. And the third question we can ask is there any duplicate medication on the person's list? So 2 drugs from the same drug class, 2 water pills or diuretics, 2 ACE inhibitors, for example. Not so common, but it does happen. And you as non-pharmacists, non-healthcare professionals, you may not know, is it a duplicate or is it being used beyond a recommended duration? But it's questions, very basic questions that we can ask with every encounter with our pharmacist or our physician.
You want to get it over with? Yes, I do. Okay.
So now I'm going to shift into
Did you
what
just
are the
get here?
consequences
No, I've been here for a little bit. I was doing
of
this.
polypharmacy, as we can mute ourselves. The consequences are listed here, and they're broad ranging. It's hard to study sometimes because people who take more medications do have more health conditions. And is it the health conditions that's causing the problems, or is it drugs? But when researchers do their job, they're controlling for other factors. So we're trying to hone in on, is it the drugs, the polypharmacy itself? And on the left side of the screen, yeah, it's pretty clearly to note a more direct link with polypharmacy. Adverse drug reactions certainly increase, drug interactions increase, and that includes both interactions with other drugs, but also health conditions, right? So non-steroidal anti-inflammatory, those over-the-counter pain medicines, can increase, make it more challenging to manage blood pressure or heart failure, for example. So we can have interactions with disease states as well. And then that adherence piece refers to the ability to follow the instructions, take medicines as instructed. And with that complex regimen I showed you, the inhalers, the topicals, the injectables, it becomes more difficult to manage medications multiple times a day, that type of thing. Geriatric syndromes is another consequence of polypharmacy. Those side effects and symptoms that appear that aren't quite a disease state, falls or frailty are great examples, but they can be due to the medications. If we're not looking for the medications, it might go unrecognized. And we'll talk a bit about falls, and we were talking, you guys even talked about falls earlier in your meeting this morning. Then there's the issues like physical and cognitive function, which we can, for certain medications, have a pretty close association. We see an association, I should say, of certain medications increasing the risk of decreased physical function. Falls is a big one, but also cognitive function, cognitive impairment. We also see just the number of medicines in general are associated. And then on the right side, hospitalization, increased emergency department visits, doctor visits, maybe lab monitoring might be needed. Having to go to be hospitalized because of an adverse reaction, a serious reaction, for example. And we even have some studies that have an association of mortality, increased mortality with the more medications a person is taking. That's a little dicier to hone in on, is it really just the drugs? But there's enough data to support that it could be. And then quality of life is huge. The more pills a person has to take and manage dealing with side effects, extra doctor visits, et cetera, you can imagine how it can impact the quality of life. So now I wanted to take a few minutes to go in, talk about specific drug classes that are higher risk. And so just not to, I always, when I give these talks, I know a little bit of information can be a dangerous thing. So but just get a sense of where these medications fall. And it's a chance for you to recognize where the higher risks are and encourage patients to get that medication review or talk with the healthcare team about their medications. So in my mind as a pharmacist, I have two different buckets of high alert and potentially inappropriate medications. It won't be as obvious to you, but I'm going to present them to you separately. And I'll talk about these 6 groups of drugs on the next slides. So the first I want to talk about high alert medications. And one way to think about them is that these are very beneficial medications, but there are some serious side effects that can happen with these drugs, and older adults are more susceptible. So with careful monitoring and good patient education, we increase the safety of these drugs. So there's three groups we think about: the blood thinners, so any drugs that increase the risk of bleeding, certain diabetes medicines that can cause low blood sugar, that hypoglycemia is very concerning in older adults, and then opioid pain medications. We just know older adults can benefit from these drugs when they are indicated, when there's a reason for them, but they also are at higher risk of having these problems. So anticoagulants, I wanted to kind of give you drug names wherever I could. So just to give you examples, anticoagulants refer to drugs like warfarin, Eliquis, Xarelto, or those brand names you might see advertisements for. And then the antiplatelet drugs refer to clopidogrel, which is a commonly prescribed one, but also aspirin is an antiplatelet. And then if older adults are combining these prescribed medications with over-the-counter NSAIDs, those non-steroidal anti-inflammatories like ibuprofen or naproxen, some antidepressants can increase the risk of bleeding, and even supplements, right? So that non-prescription medication use can be very challenging and increase the risk. With diabetes medicine, there's some oral drugs that we know are higher risk in older adults. We like to avoid them. I'll come back to those also with in the next slides. But insulin products can be a concern. And if patients are taking more than one diabetes medicine, they're not eating properly, that increased risk of low blood sugar is very concerning. And also older adults the signs of low blood sugars aren't as easily, are different and not as prominent. They're more subtle in older adults. They might not realize they're experiencing low blood sugar. And then opioid pain medications, again, very important and a good tool in the toolbox when severe pain is involved. But there's interaction concerns with drugs we also commonly use, the benzodiazepines or gabapentin you might have heard of, risk of respiratory depression. So we worry about interactions with these drugs, but also constipation and fall risk is a concern. I want to talk about the other half of the medications on those six circles I wanted to talk about, potentially inappropriate medications. If I had you in a room, I would ask, how many have heard of the Beers criteria? And I'm hoping some of you might have heard of it already, but if not, just to mention, it is a list developed by geriatricians, even geriatric pharmacists and physicians in this country to identify medications that are at high risk, that should be avoided in older adults when safer drugs are available, and often there are safer drugs available. So it's known as the Beers list. It was developed by Dr. Mark Beers, not after the drink that we do on the weekends, but it's been first developed in 1991. It's updated regularly now, and it's a really great tool. You can access it at the AGS, American Geriatric Society Foundation website. I have that link up there for you. But we basically want to avoid these medications because most often there are safer drugs available. It doesn't mean you cannot prescribe these medicines. It's not black and white. It's just a gray and a yellow cautionary. Let's think about it and educate our patients if we use these medicines, and use them as little as possible. But so some examples, right? Because you're thinking, what are these drugs? So benzodiazepines and non-benzodiazepines. The first two rows I'll talk about together because we have the same concerns with these drugs. I have examples of what the benzos are and what the non-benzos are. But we worry about fall risk, motor vehicle accidents, and effects on the memory, and even dementia. With prolonged use, we're seeing an association with dementia, irreversible cognitive changes. So we want to really minimize these drugs and avoid them when possible. Older antihistamines are a big one, and I mention this because they're available without a prescription, right? Diphenhydramine is Benadryl or Tylenol PM. It's the PM part that's added to Tylenol for that sleep medicine. The Z-Quil, a lot of promotion of those NyQuil products. Z-Quil contains an older antihistamine, diphenhydramine. We worry mostly about the central effects, the effects on memory, confusion, and again, that risk of dementia possibly developing in patients taking these older antihistamines, and I'll talk a little bit more about the concerns behind them in a second. Proton pump inhibitors. People are on Nexium and Prilosec for years when if it's for simple reflux, it really should be a short duration. And that's where I mentioned a duration that we know of, what we really want to focus on, 8 weeks. Then stop the medicine as long as it's for simple reflux and restart it if necessary, rather than continue it for years and years. So we worry about C. diff, diarrhea, bone fractures, pneumonia. Muscle relaxants are examples of potentially inappropriate medications, and then those certain diabetes medicines come back here, those oral drugs, because of that low blood sugar risk. Other drugs that are potentially inappropriate are anticholinergic. And I don't shy away from using these terms because I think we need to be familiar with some of these terms when we speak with our healthcare team. We encourage, and if you can be familiar with these types of risky medications and encourage your clients to seek a drug review and talk about their medications, it's really important. So anticholinergic medications, I'm carefully watching my time because I want to leave time for your questions. They have in common how they work in the brain. They block this messenger called acetylcholine in the middle of box there. And this messenger in the brain is directly involved with memory and learning. And when we block that messenger in the brain, guess what happens? It affects our memory and learning abilities. So that's that memory piece with these drugs that we're very concerned about. When I mentioned the antihistamines on the preceding slide, it's because of these anticholinergic effects. I can't give you a simple list of anticholinergic medicines because they're across the board, right? And different drugs have different degrees of this side effect, if you will. We use them for overactive bladder, urinary incontinence. We use them for depression. We use these drugs for allergies, as I mentioned, the Benadryl. Insomnia, those sleep aids, COPD, the breathing condition. But what's in common with these drugs on the right side is that risk of confusion and memory loss, dementia, delirium, fall risk. So you can see why these are so critical for older adults, and we want to avoid them when possible. Even things like dry mouth and dry eyes can be very problematic for our older adults. So again, just to give you some examples, I won't spend time on this slide, but it's a resource for you that there's to know which antidepressants, examples of this overactive bladder medicines, not all of them, right? We have a newer group of drugs for overactive bladder that don't have this side effect. And I mentioned the sleep aids, over-the-counter products that are on the far right side. And patients are always asking me, can I take this? Someone last week, can I take the Z-Quil? And I had to explain to her why, no, I really don't want to recommend, I don't want her to be taking that Z-Quil. Also on these list of potentially inappropriate medications and the Beers list, and for example, are drugs that increase fall risk. And we know that even the more drugs of medication a person takes, there is that increased risk of a fall. So 4 or more drugs versus 10 or more drugs. But we also hone in on specific types of medications. So I've listed these drug classes. We already talked about the benzos and the non-benzos. We talked about the older antihistamines. I mentioned opioid pain medicines, certain antidepressant drugs in general, because they work in the brain, right? It kind of can slow the brain down and increase that fall risk. And even certain blood pressure medicines, we worry about those. If they can, water pills, diuretics can maybe lead to low blood volume and increase that dizziness risk. Blood pressure medicines that drop the blood pressure too low, like overtreatment, could cause dizziness when standing up, that orthostatic hypotension. So that's why those drugs can increase blood fall risk. And then I kind of touched on this before, but over-the-counter products are really important also, can be potentially inappropriate. So I've listed them here. And Tylenol, we worry about the liver issues if patients are taking too much. And Tylenol is available in a lot of different products, a cough and cold product, a Tylenol PM. They might be taking Tylenol regular for pain during the day and then the PM at night, and a cough and cold prep. So it can be a concern. I mentioned the ibuprofen and naproxen, the non-steroidal anti-inflammatories, and I've already mentioned those proton pump inhibitors. So again, these drugs aren't like, oh my gosh, never, but it certainly increases the risk of problems. If I had time, I wanted to mention Richard Simmons. The story with him is he died in 2024, and the family did an autopsy, a blood report, and the report was there were no illicit drugs in his system, and he was only taking medications that the doctor prescribed. Therefore, with the implication that it wasn't the medications that contributed to his death. He had a fall and then was found unresponsive, is the nature of his death. And the point of my story, when I give talks, I love sharing this. Sorry for his death. If you remember, Richard Simmons was such a character for us. As the health guru. What was found in his blood system was diphenhydramine, which is that Benadryl, anticholinergic effects, trazodone, which is a medicine used for sleep, and zolpidem, which is a Z drug, a non-benzodiazepine. So those were all fall risk medications for him. And he had a fall, and that contributed to his death. He also had heart disease. So I venture to say it wasn't that the medications had no role. I think they could have played a role. So hopefully you understand, after seeing the medicines I'm concerned about in general, how that could be. Okay, so let me talk about these strategies, and then we'll have time for Q&A and get us all about our days. So I have 4 tips I would always recommend. Medication list is by far the most important tool I think we can have. It needs to be, however, current, complete, and accurate. So it has to be updated on a regular basis and accessible so we can share it with every provider at every patient encounter, with your pharmacist, and every physician who's prescribing. I always tell people you need to include 3 different categories of medications on that list: prescription medications, over-the-counters, and dietary supplements. They are all drugs. They all can have interactions and side effects. And it's also important to be honest and note, what are you actually taking at home? Are you taking things differently than what's on the label? Are there other medicines that maybe your doctor may not know about? Again, add in those dietary supplements and anything over the counter. Are you taking things differently? It says 3 times a day, but you really never take that middle of the day dose. So you take it at night, you double up on the nighttime dose, for example. Be honest about how you're taking these drugs. And key information, why are you taking it? That goes back to what I was saying before. If you don't know why you're taking a medication, it's definitely a place to start to get at this polypharmacy concern. But also include the prescriber name and when that drug was started. And this is really important down the road when it comes time to look at this medicine list and you're wondering, and as a professional, I'm wondering, why is this patient on all of these medications? If I can understand who started it, maybe when it was started, it makes it easier to decide, can we try pulling back on this medication? Is it still needed today? I worked with a client who was on a diuretic for years, and when I prodded further, he was able to tell me it was started before he moved to St. Louis several years ago, before he had some surgery for his urinary condition. So is it even needed today? So we were able to kind of backtrack a little bit and get a little history. So it's important. And so if we can do this going forward, who prescribed it and when it was started, it helps in the future. And of course, share it with healthcare professionals, as I already mentioned. We need to know our medications, just basic information. As I mentioned, the reason is really important, but also the goals of therapy. Why am I taking this? And how will I know when it's effective or not? That helps us monitor or watch for the good effects, right? Are we looking for blood pressure reduction? Are we looking for improved mood? Are we looking for better sleep? Whatever it might be. Or are we looking for side effects that we have to be aware of? Maybe the drug's doing okay, but we're having harms from the medication that might require an adjustment or perhaps switching therapy, right? So we have to think about what are the goals, what's the good and the bad I need to be watching for. Pharmacists are drug therapy experts, so use us. When you get a new medication, encourage your clients to talk with a pharmacist. Say yes at the pharmacy counter. Often, hopefully someone's asking, do you have any questions for the pharmacist? I always joke that no one's ever making eye contact, but it's a good question. And if say yes, I want to just let me hear what the pharmacist has to say about this medication. Errors can be caught. Um, Errors can be prevented by just having conversations with the pharmacist to understand your medication better. On this next slide, I have 8 items to know. Yep, sorry, I know it's a lot. Sorry about all 8, but they all have some role. Focus on the key information. Know your name. Errors can occur if people don't realize that cardizem and diltiazem are the same medication, for example, or Synthroid and levothyroxine. We can avoid errors if we know both names. Reason for taking, as I've already mentioned, instructions 3 times a day. Does that mean with food? Does that mean every 8 hours? It's important to know how to take it. And it's also clarification. I met with she was actually a friend. I was having lunch with her, and she was telling me about having to start Eliquis, right? And I know this is a twice daily medication. And she was telling me how she's taking it once a day, and she's all, excited that she has this new therapy, and she was talking with me about it. And I'm like, are you sure it's only once a day? She went home and looked at that bottle. It said twice a day, but somehow she didn't see it, didn't pay attention, just assumed whatever it was an error, an inadvertent mistake. So, how to handle a missed dose. I put that lower on the list because you can always call the pharmacist if that happens, but it's something it might be nice to know. What about refills and continuing it? But certainly know the common side effects and maybe serious side effects so I know when to call the doctor if I notice a symptom, right? The next recommendation is just to advocate for medication safety through communication. Patients are part of the healthcare team. They're the most important part of the healthcare team. We're very focused, especially with older adult care, on person-centered care, what's most important to the older adult. So how do we get engaged with drug therapy, even making decisions about choices of this drug or that drug, or starting this drug or working with non-drug therapy instead? So these are all what the communication might look like. Regular medication review, really, really important by a qualified healthcare professional. I'm going to say pharmacists are the best people to work with. We have the greatest knowledge, but we may not always be accessible. So it makes it more challenging. I wish I could say this is how you access your pharmacist and they will always be available for review, but hopefully they will make themselves available. At the retail setting, some pharmacies have a program set up where they will do medication reviews, but ask if you want a pharmacist to go over your medications, ask if they can meet with you, set an appointment at another time, not when it's their most busy time in the pharmacy and not when you're right there picking up a prescription, but ask there. There's people like me, senior care pharmacy specialists, where you can have private medication reviews. Typically, our services are not covered by Medicare insurance or Medicare. There is the chance to get a comprehensive review through your Part D program. We can go into that if you have more questions, but that's another option, or even your physician. But the physician, sometimes it's harder for them to be more critical of a medication list that they've been prescribing, right? So those outside eyes sometimes can be helpful. But we want to look for the duration, the safety and effectiveness for your situation, your kidney function, your combination of medications, your health conditions, for example. Are there other alternatives that might be safer? But also, it's really important to think about maybe non-drug treatment might be a way to go, right? We always want to, with any health condition, do that non-drug stuff as much as we can and along with the drug therapy if the drug therapy is needed. So this prescription checkup is really important to identify meds that may no longer be needed or that could be harmful. And then my take-home points are here that polypharmacy could be appropriate, but we worry about that inappropriate polypharmacy. I talked about the consequences. I highlighted some high alert medicines and those potentially inappropriate medication, mostly noted by the Beers criteria, and hopefully given you some strategies to be safer about those medications. And on this last busy slide, if I can have that up, I just wanted to connect with me. So I have a newsletter in the center QR code. I love to do it monthly, even every other month, but right now it's like quarterly. I'm very bad, but I do want to connect with you guys, provide safe information about medication use, a recent study, whatever. I try and put that kind of stuff in my newsletter. And then following my social media. And if you are interested in the book, I wanted to throw that out there too for you guys. And with that, I hope I did okay with time, and I'd love to hear feedback and questions.
Thank you
That
for
was
that. I have a question for you. So
Okay.
we kind of briefly talked about how it's important to have somebody looking over these medications, but how do you find somebody like you or yourself to actually do this, do what you do?
So, and I should put it in the chat if I can. So there, as I mentioned, there's a database of senior care pharmacists through one of my pharmacy associations. And so I just have I need to stop sharing so I can get to chat. And I'll put the website. Hold on, I'm playing with my
And if you
screen. So
send it
sorry.
to me, we can post it as well, Hedva, or you can
Let's
put it in your slides and send me an updated slide set and
let's
I'll
do
put the,
that. Okay. But
okay.
it's helpwithmymeds.com, and there's a senior care pharmacy database. I'm sorry, I was just playing with my screens and technology. So forget right now in my off sheet screen share. I just want to make sure.
We're still seeing your last slide,
Okay.
but that's fine. There you go.
Okay. I just want to make sure I'm technology okay here. Sorry. And I can put that up back. I love, again, like I said, love for people to connect. So, helpwithmymeds.org, there's a senior care pharmacist database. So that's one way to do it. The other is to maybe ask at your local physician's office if they might have a pharmacist involved there. Ask at your area agency on aging. They might know about pharmacists like myself who does this concierge. And I mentioned the Part D plan, where people could call their Part D plans to ask, am I eligible for a comprehensive medication review? And every Part D plan must offer these, but the criteria for eligibility varies across plans. So that's why I can't say whether you would qualify or not. Each person would qualify, but they need to ask. So those are some ways to get at it, but I will definitely get that link with the slides. So thanks, Dara, on that.
Yes, and I have another question too. I think as we see more and more shrinkage, I'll call it shrinkage of the retail pharmacy and resource issues at every retail pharmacy I am at, and people being encouraged to use mail order pharmacies. Do you know if mail order pharmacies allow that, enable this and support this, or really if people have this combination of retail and mail order, they need to be thinking about a concierge approach?
I struggle very much with the mail order because you lack that in the face-to-face visit and an opportunity with a pharmacist and the chance for a pharmacist to get to know you.
Yeah.
So, and if you're forced to a mail order, there's not much you can do if your insurance is
Mhm.
mandating that. And I struggle with that very much. So I would, what would I offer? And you're for that there's always a 1-800 number to ask questions about a new prescription. I'm always going to support a pharmacist-patient relationship, but I struggle because if it's not covered by insurance and healthcare is, we're so used to having a simple copay, could everybody afford it? But it certainly would be if you take multiple medications, you're concerned about being over medicated, your doctor's not listening to you, that type of thing, or coordinating among the different doctors, a concierge type approach could be very, very valuable.
Yeah, it gets more and more complicated. It seems to get more and more complicated, as you navigate the requirements of various insurances and different Part D plans, and not to mention your supplements and over the counter. It's really hard to get the whole picture. And I know you have to advocate for your clients, for yourself, for the full review.
And I will put a plug in. Independent pharmacies don't always have the same pressures as your big box pharmacies. So I always and I don't know what the situation is, Idaho. I'm talking with some people in Delaware where I'm seeing there really are these pharmacy deserts are a huge concern in rural areas, especially. So in Idaho, I presume you are seeing that a bit.
Mhm.
So yeah, I'm not sure what the best answer is, but looking for the concierge if you don't have a local pharmacist, but if you do have a local pharmacy, support it as much as you can.
I think it's advocate and ask, and we still have a large population of people in our country who were raised with the doctor is always right, and they just say yes, right? And so challenging that knowledgeable authority is still hard for a lot of people.
And that's where hopefully my information will encourage people to feel empowered to ask. And I think that generation is turning over so that the baby boomers are much more comfortable asking information, almost to a fault that they don't, they're very distrustful, right? We got to trust. But to find, I'm taking a lot of medications, doctor. Could we just go over everything, make sure everything is needed, and research has shown that when we look at this de-prescribing, pulling back on medicines, patients bringing it up starts the ball rolling. Doctors may not bring up, oh, what are you ready? What are you looking to stop today? Do you think you're over medicated? It's patients bringing it up that the doctors will then address that potential over medication. So really important for that communication piece for patients to advocate.
Thank you so much.
Yeah, I just see we're at time,
Um,
so I'm so grateful that, and I appreciate the comments. I'm seeing some of that. I hope it was helpful. Um, but again, Dara, thank you so much for pulling me in, and Lake for working with me to get this out. So thanks.